Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session! Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So to introduce our first speaker, Alan is a clinician, teacher, and lead physician for behavioral medicine in the Department of Family Medicine at the University of Ottawa, and is a clinician educator in the Department of Examinations, Assessment, and Certification at the College of Family Physicians of Canada. He is currently based at the Primrose Family Centre. His clinical interests include the consultation in family medicine, valent groups, the medical humanities, and assessment in medical education. So Dr. Ng, please feel free to share your screen and begin your presentation.
So thank you. Coincidentally, this morning we are doing the resident practice SUS, so this is timely. I'm speaking to you primarily in my role working with the College of Family Physicians of Canada, as I am a clinician educator in the Department of Assessments. And this is going to be just a brief, very brief and quick run through of a project we're currently involved in, looking at what examiners think of the simulated office oral and what the implications are for validity. Let me just flip my slides. Okay, so the team, just to introduce the other colleagues working on this with me, Dr. Amal Kaminska from University of Northern British Columbia, who's a researcher, and Brianne Orchak, who's a instructional designer at the Medical Council of Canada. And together, we've been working on this project actually for the last couple of years. I don't have any conflicts of interest. So what I'm going to briefly talk about, I'm going to talk just to situate everyone, because some of you may not know much about the simulated office oral, briefly talk about a validity framework that we use in health professions education, particularly, and then go into the actual examiner needs study that we have been working on. So what is the simulated office oral? Most of you will know and will have experienced it. And some of you will be examiners or teaching residents about how to do this test. So it's essentially, the main things to remember for this morning is it's a summative exam, it's an OSCE, so that's an objective structured clinical examination, and it's part of the decision process in order to obtain full licensure. So this is pretty big and important exam. And because it's a summative exam, things to remember, it's high stakes, okay? So because a judgment is made on whether a trainee has reached a certain standard, and because it's high stakes, it's got to be fair, right? That is probably the most important thing of all with any summative examination. It should be fair. So if it's going to be fair, it's got to be valid, it's got to be reliable, it's got to be equivalent. And by that, I mean, if you do this exam in Calgary, or if you do this exam in Ottawa, or if you do this exam in St. John's, you should have the same or equivalent scores or decisions that are made even across different cycles. And it should be acceptable. So stakeholders, that's us, that's the public, that's the candidates, should find this exam assessment process credible and the results credible. Now, the SU is an interesting exam. It's a balancing act. When you look at what is tested, there are actually two portions to it, because although one often considers it to be a test of patient-centeredness, thinking about it in that sense, in that way, is actually an oversimplification. That there's a tension between being patient-centered and doctor-centered, because along with being patient-centered, the SU also tests specific, what I would describe as doctor-centered task, because you need to know your medicine, you need to be able to hypodeductively make differential diagnosis, analyze data, etc., and pay strict attention to time management. So it's a pretty complex exam. It actually tests, the construct that we're testing is actually the office visit in its entirety. And there are lots of things that happen. There are lots of ways that that you can look at the office visit, and there's a lot of literature. This is an example of some of the literature, which I have to say, sadly, I have read. I'm a bit of a consultation nerd. But you have to remember that this is the prime tool that we use. So it doesn't matter whether it's in person, whether you're doing phone consultations, or whether you're doing virtual video consultations. The consultation is the consultation. So because we're talking about examiners, we'll just briefly talk about who these examiners are. Basically, to be an examiner with the college for this exam, you have to have active certification with the college. And if you are actually portraying one of the roles, you have to meet age and gender requirements in order to portray the roles. And that's basically it. That is the qualification to be an examiner. For quality assurance, we have coordinators and assistant coordinators who observe and oversee the interaction between the candidate and the examiner. But to be a coordinator or an assistant coordinator, you must have been previously an examiner for a minimum, I believe the number is 3 SU exams before. So coordinators and assistant coordinators are also examiners or have been examiners. And before COVID, and we'll talk a bit about COVID in a second, the training of the examiners was one day before on the Friday, because the exam's always on Saturday, Sunday. There was one day of training, which consisted of a half-day exercise where we calibrate the examiners with video. It's very similar to what, for those who are familiar with doing SUs in the department, what we do on the Tuesday or Wednesday night, which we actually did this week before this morning. And then there's a half-day run-through in the afternoon with mock candidates who are then scored. That's what the training is. And just to remind you of who the candidates are, essentially there are 2 classifications: trainees, residents, and practice-eligible candidates. The most important thing to remember is that in both categories, the candidate is deemed to be practice-ready to work independently. So this exam is basically to just really to make sure you are fit for independent practice. So that's the level at which this exam is situated at. So that's important, again, when we're trying to decide on examiner training. Now, I'm going to talk briefly about something called Kane's validity framework. So when we talk about validity, we are, a test is not valid in and of itself. So you can't say the SU is valid. What you can ask yourself is the SU valid for the purpose for which it's meant to be used? And that's the important thing about validity, It's not a property of the test, it's a property of what you're going to do with the results. And Kane described this framework, which is actually quite complicated, but all intertwined with each other. Essentially, there are four main areas that we look at. Firstly, scoring, how accurate the score is, and does it actually reflect the competency? Generalizability, which is in the test world, how well does the test represent all possible testable items? And that has to do with number of stations. The SU has 5 stations. Obviously, the more stations you have, the more you can generalize. Extrapolation, which is what is tested in the exam real or comparable to what is actually done in practice? And then finally, what do you do with the scores? That's the implications. Does the interpretation of the results justify the use of the exam? So these are the sorts of things that are looked at. Now, this study looked at examiner training specifically. And examiner training basically fits here because the examiner has to observe and actually is the role player as well. And also fits with actually finding, generating a score. And because of this quirk in our exam that the examiner is also role-playing, extrapolation is also a key part of looking at validity with examiners. The knowledge gap is that to date, there are no published reports, reviews, or analyses which explore SU examiner needs, okay, and their ability to assess candidates or to make judgments. And there are no recent published studies on validity of the SU, although they are definitely coming. So what we did was a questionnaire was created, and the idea was we wanted to conduct a needs assessment to decide and to help plan what we could do to improve examiner training. Okay, so, and maybe at the same time identify possible validity threats. So 2 of the researchers, myself and Brianne, we used an iterative process in order to create this questionnaire, and it was offered in English and French. First question was consent. The next questions had to do with just gathering demographics, gender, experience as an examiner, experience as a clinician, how much time you spent in generalist practice, how much time you spent teaching residents or medical students. And then we had some specific qualitative questions. Firstly, we wanted to know what patient-centered care meant to examiners and whether any specific approaches were used, models were used. We wanted to know from examiners what they thought the role or goal of the SU was in the certification process. We wanted to know how confident they felt in their ability to assess patient-centered behaviors accurately and consistently. And then we wanted to ask them if they had any specific challenges that they found as examiners. So those were the qualitative questions. Now, I will mention COVID, because when we started this, actually, everything was developed just before COVID hit in 2020. And the data gathering actually took place in June and July when we were just really ramping up in the pandemic. And the SU was actually suspended by the CFPC for the spring exam 2020. And it did not resume until fall 2021. And it did so in an online virtual format. So the data we have collected reflects the thoughts and perceptions of examiners using the in-person format, okay, which is now no longer happening. And I'll talk a bit more about that in a second. The participants were basically a list of every examiner. We had a database at the college, and we had 540 names. So anyone who examined in the college between 2015 and 2019 was sent a survey. And it was approved by Février ethics, actually, and written consent before we started the study. And the survey was implemented using Hosted in Canada Surveys, which is a Canadian based server. And basically, it took 6 weeks to get the data. We started June 1st. We sent a reminder 3 weeks later, and then we closed it permanently 6 weeks later. So the results, essentially, we sent 540 surveys, and this is basically this just shows how we weeded everything out. Of those 540, 366 were opened, and then we eliminated because in order to use the data, some people didn't answer all the questions, some people didn't consent, etc. We ended up with 284 in the analysis, and that was a response rate of 53%. And it's a mixed method study because there's demographic, quantitative information, but also the primary sort of the meat of the study was the qualitative aspect of it. And we used something which, and I like to acknowledge Sharon Johnston for helping me with this technique called immersion crystallization, which is a form of qualitative research and analysis. And so what we did was essentially the data was just individually read and reread using this immersion crystallization approach. So you just read and reread to form thoughts, ideas, and themes. We developed a coding template using NVivo 12, and then we had many virtual meetings to discuss discrepancies, interpretations, coding, which we settled by consensus, and we conducted a thematic analysis. So here are some of the results. Basically, demographically, 90% of the responses came back in English. There's 54 to 46% split gender-wise. We had a mix of people who had only been examiners, about 42%, and then the rest had either been an assistant or a coordinator, which means that they have been examiners as well previously. There was a good spread as far as years of practice, from just out of residency to very experienced and time in practice. We also asked about percentage of time in general practice, because this exam is meant for generalists. It's meant for the person, it's not meant for, or it's not testing the skills that someone who's doing enhanced skills and a focused practice would do. So we wanted to get an idea of that. So here are basically a summary of what we found. The first question, which was based on how much do you know about patient-centered care? Do you understand it? So overwhelmingly, the examiners had an excellent, very in-depth, very rich knowledge of what patient-centered care is. The themes being that it's specific to the particular patient, there's shared decision-making, common ground, it's at the core of the doctor-patient relationship, listening to patients, holistic care. So that was all very clear. Here's a exemplar quote from the survey. Doctor-patient relationship is essential to understanding health problems in their proper context, adhering to a shared decision-making process, which takes into account patient values and points of view. So overwhelmingly, the respondents understood this, certainly. We asked about what they used as far as models, and the Fife model was probably the most common one that was sort of brought up specifically by name. Many just referred to their approach or their model as the biopsychosocial approach, and then a few mentioned other models such as Calgary-Cambridge, Epstein, and some mentioned no model at all. We also then asked, what do you understand about where the SU fits in the certification process? Essentially, again, the responses showed that the examiners understood quite clearly where the SU fits, that it's a direct observation, it helps to standardize the process. We're testing a patient-centered approach, which is unique to family medicine. And but also they understood that it had to do as well with the medicine, being able to create management plans which were medically acceptable, but also reflected the needs and desires of the patients. So the next question dealt with confidence, and what was interesting is 90% of this is all self-report, so 90% said, I'm very confident in being able to assess patient-centered behaviors. And the most common reasons were, firstly, they just said, I know what a good candidate is versus a mediocre candidate, and that's based on my experience as an examiner. And others said, I am very confident because this is what I do, and this is based on my own knowledge of being a patient-centered physician. So those are the reasons that they were confident. The 10% that were not so confident or ambivalent actually gave the reason, not because they didn't know how to do it, but it was because the exam structure made it very did not give them confidence. And some of the reasons were that these are all quotes, that it was too formulaic, not reflective of real practice. The illness experience has been reduced to FIFE, feelings, ideas, functions, expectations. Then there were quotes about how they play the case, the fact that they have to actually act as the patient at the same time simultaneously as acting. So as marking. So then the last bit was what challenges, and you could divide these into 3 categories. Scoring, firstly, they found that the marking section can be challenging if you miss one bullet point, even though it seems to me that this candidate knows what they're doing, they would score a non-certificate. So that was a challenge that was explicitly mentioned. The other one was that the what we call auto-fifing, or trivialization of the illness experience. So the fife was seemed to be forced and uncomfortable. So that was something that they found a challenge. The role play, the cognitive load, just being consistent, giving the information and being able to score while doing the role play, and just trying to remember which candidate said what, because once you're into your 3rd or 4th candidate, it definitely they all sort of come together. The other things that were mentioned was the 2-problem format, the types of problems, the limitations of no data. So because you always meet the patient without knowing anything about them, and the authenticity of the role play. And this is just a quote that, these are some exemplar quotes. Cases can be overly complex to expect residents to get to 2 issues in 15 minutes. Lack of portrayal of other, this is a direct quote, Indigenous population, but essentially the point which was raised by many is that it does not seem to represent a full representation of the Canadian population. The role play, also just knowing how much information to give or not give, was a challenge. And also the fact that because the physician, the examiner knows the marking scale, there can be unintentional bias when questions are being asked. So essentially, what we took from this is that, examiners are expected to have an in-depth knowledge of patient-centered approaches, and this was shown in the survey, certainly by self-report. The construct was understood in the sense that they were clear what this exam was being used for, that it's a summative, it's a standardized test, and they were very confident in their abilities, and the ones that weren't confident blamed the exam, not themselves. So some of the things that we are sort of looking at is the scoring scales don't always correlate with examiner perception of true competence. There's trivialization of the competencies, and that is something that examiners feel uncomfortable with. There's a very heavy cognitive load. You have to score from recall because you can't score as you're going because you have to stay in role, and the quality of the acting is a significant feature as well. There's the 2-problem format, doing 2 problems in 15 minutes with no data, and the informed patient providing a potential for bias. I'll just quickly mention what COVID-19, because we moved to a virtual format in 2021, the SU is actually going to continue in the same virtual format. We are not at the moment contemplating going back to an in-person assessment. However, having said that, the format and the structure of the SU is not changed at all. So the same potential validity threats that existed with the in-person assessment remain in the virtual format. There are legitimate concerns that being virtual actually makes it even more difficult to examine candidates because it's just harder to identify nonverbal behavior. So what's next? We have to consider trying to reduce the cognitive load. We are actually doing that by introducing assessor bias training and considering more intensive training to recognize competence. The exam, this brings up questions about the exam itself, and the college is looking at various things such as the scoring rubric, the cognitive load, and the station structure. And that is a very quick summary. So I'll take any questions or comments. So I don't know if anyone has any comments or questions.
Hey, I'll jump in. This is phenomenal work. Really exciting to see so much of like the last 10 years of what you've been doing presented. Something that struck me, we many of us on this call went through the SUS, and so it's interesting that you're asking people their experience as sort of examiners of something they went through. In looking at the definition of patient-centered care, there would be a range of what would be considered patient-centered care. And I was struck by some of the comments of, with 90% confidence, I know what it is. And some of it seemed to suggest because I do it. And I wondered whether there was a way of capturing how much are you evaluating how similar the trainee is to yourself, and whether that would be a problem with this style of examination, given that you're measuring something that should have a range of approaches.
Yes, that's an excellent point. So I think one of the concerns that we have is in order to determine that, you need to have better training. You need to sit examiners in a room probably for a day or a weekend retreat and have them watch tape and then have a discussion. Because you're right, the self-report, it's a self-report that everyone's confident that they understand patient-centeredness. There's a difference, though, between understanding or doing it and assessing it in candidates. And now, because it depends a lot on experience, you can't just say, a clinician might say, like, and a dermatologist might say, I know what this rash is just by looking at it. And that, that's me as a relative novice would say, wow, that's amazing. How did you know that? I've got to sort of go through this whole process. I have to have a script to think about that. Now, when you're saying, well, I know that this candidate is a fantastic candidate. Like, I know that this person knows what they're doing in my assessment. Again, that takes experience and training. So we are aware, one of the reasons for doing this survey is to determine where we're going to put all our, I guess, our eggs as far as training, how we're going to train examiners. And I don't think we need to spend a lot of time teaching them about the patient-centered method if they're saying they understand it. What is more important is whether they can assess it in candidates, which is not actually the same thing. So yes, I think, I don't know if that did that answer your part of your question. It's Denise.
Yeah, thanks.
Yeah, hi, Alan. Thanks a lot. I'm someone who was an examiner, only twice though, when it was still in person. And I am wondering if there is a difference between the experiences of recent grads who had just sort of done the exams themselves in the last couple of years, or who trained in that format, versus people who had a lot more experience and maybe were not trained quite in the same way.
Examiners you're talking about, right?
Yeah, examiners. So for example, when I was a SU examiner, it was fairly recently out of residency. And so I had just done the SUs.
Yeah.
And did you notice any real differences in experience of the examiners and their attitudes towards the exam, having just done it themselves?
Right. So we couldn't tell from the data because the data is completely anonymous. So we could not trace actually, we can actually, because we could do it. We have in vivo and we could figure that out. But we did not look specifically at the comments and how much experience they had. Like we didn't make that direct link. We were really just looking at general themes. So what I would say is certainly there's a difference. I think I talked about this already. Even though you've been in practice for many years, if you've not been an examiner for many years, that there's a difference. It does require intensive training to ideally now practically and cost-wise, it's a different story, but ideally you really want to have examiners, in my opinion, more intensively trained. That takes work. that takes time and that takes money. Claire, just in the failure rate. So the failure rate is fixed. It's always the same failure rate because this exam is norm referenced, so it's curved. So it's -2 standard deviations from the mean for practice. So for residency eligible candidates, the national reference group. So the failure rate for that group is very consistent because it's norm referenced.
So Dr. Rita Hafizi is where she practices full scope family medicine and mentors medical students and residents. She is an assistant professor at the University of Ottawa and the undergraduate clerkship rotation director for family medicine on the Anglophone stream. In 2021, she was the recipient of DFM's Undergraduate Educator of the Year Award for her outstanding preceptorship and contributions to medical education. And last year, she was honored by the CFPC with the Early Career Development Award. Her professional interests include medical education, women's health, geriatrics, and refugee health, to name a few. So Dr. Hafizi, please feel free to begin.
Thank you so much, and thanks for having me this morning. My talk is going to switch gears a little bit and talk about more about like technology and medicine. So it's called Medical Apps for Your Practice. I also want to say I was not involved in developing any of these apps, and I don't get money for promoting them or talking about them. So no conflicts to declare there. And so over the next 15 or so minutes, I will tell you about a few apps that I find useful in my clinical practice and that I've asked colleagues about and residents what sort of apps that they like to use in their busy office setting. So I thought it'd be helpful to share a few cases. So our first patient that we're seeing this morning is Veronica. She's a 32-year-old woman. She's presenting with a 3-day history of dysuria, urgency, and frequency. On exam, she's well, no fever, no CVA tenderness, but her urinalysis is quite suspicious for a urinary tract infection. She tells you that she's 9 weeks pregnant and she's taking prenatal vitamins, but otherwise healthy. So some questions you might be asking yourself, or that I sometimes ask myself, is, well, do I want to treat this empirically or wait for the urine CNS? And because she's pregnant, are there any antibiotics that I should avoid, especially depending on where she is in her pregnancy, sort of early pregnancy versus if she's towards the end of her pregnancy? So some apps that I'd pull up in this case is my handy anti-infective guidelines, also commonly known as the Orange Book, that you guys have probably seen, developed by Mums Health. And it was first created in the 1990s to try and help with antibiotic stewardship and curtailing unnecessary antibiotic use. It is available on the App Store for $24.99. It has a very high rating. You could also buy the book, but if you're trying to move towards sort of like technology and sort of having quick access to things. One of the downsides to this app is that it's only available for iPhones and iPads. So if you're an Android user, you don't have access to it. But again, the book is available for $29.95, and you probably already have a copy, but they do try to update it. In our patient's case, she's got a genitourinary infection. So I'd click on that. And to answer our first question, would you want to treat her empirically? We could use the UTI clinical decision aid, and then later look at how would you treat cystitis in a pregnant woman. So I'll click on the decision aid. So once again, she's had dysuria. There were leukocytes on the dipstick as well as nitrites. So her score is 3 points. So it's recommended to start empiric antimicrobial therapy without waiting for the urine culture, owing to a high likelihood of infection. And if we go back to see what are the treatment options in acute cystitis in a pregnant woman, you'll see cephalosporins, amoxicillin, nitrofurantoin. Second line would be Septra, but it's important to also read these footnotes. So it says here, best to avoid trimethoprim and sulfamethoxazole in the first trimester because of concerns that the trimethoprim may limit the availability of folic acid. And then you also want to avoid it at term as well. So having said that, what antibiotic would you guys choose? Does anybody want to type in the chat or take a guess? So yeah, a few different options there. So good, great. As I mentioned earlier, it's not available for Android, but a free alternative is, and that is available for Android, is Bugs and Drugs 2.0, developed by Alberta Health Services. I will say though, I tried using this app, and I will say that I found the Orange Book to be superior and more user-friendly, and for the information and content, I found the anti-infective guidelines more up-to-date and relevant to Ontario. Yeah, this is a free alternative. And then another app specifically for drugs in pregnancy and lactation is this one here. That's by Dr. Briggs and his group. It's based on the 11th edition of his book. The app itself is free, but you do need a subscription, and the subscription is about $80 or so. It's available for both iPhone and Android. There are a few apps that I'll share later on in my presentation that also have sections for treating patients who are pregnant or nursing. So you don't necessarily need to invest in this app, but if you are someone who sees a lot of prenatal patients or pregnant patients, it might be worth getting. So our second case is a pediatric patient, Jamie. He's 5 years old. He presents to your office with a 3-day history of fever, sore throat, and pain with swallowing. He's otherwise well, not on medications. He hasn't had any sick contacts. He hasn't traveled, and his COVID rapid antigen test was negative today. On exam, he's got a fever, and he's got exudates on his tonsils. So you're highly suspicious for strep in this case, but again, if you were kind of on the fence, you could use your Orange Book again and use the clinical decision aid. His mom also tells you that he's allergic to penicillin. It wasn't anaphylactic, but he did develop some hives. So what would you prescribe instead is the question you're asking yourself now. So again, you can either consult your Orange Book if you've already have it, or you downloaded the anti-infective guidelines. But another free alternative that's available for both iPhone and Android is First Line Clinical Decisions. A few years ago, they used to refer to it as Spectrum, but now it's called First Line. And it's a point of care tool for infectious diseases in kids. And you can customize it to, you know, the hospital or institution you're working at, or the city or province. So for us, our institution would be the Children's Hospital of Eastern Ontario, or CHEO. So in our case, we're worried about pharyngitis. And it says here, okay, group A strep is the most likely pathogen. It gives you a little bit of information about it. If you want to see the antibiogram, you can click here, and it tells you, it's universally susceptible to penicillins and also to cephalosporins and other beta-lactams. And you've got the percentages here. It also specifically has a section that says, if there's a penicillin allergy, what are some alternatives? So I think I'm going to choose cefuroxime. And I can never remember, okay, how many mgs per kilogram. So I always have to look that up. So I find that's why these apps are also helpful. So for pediatric dosing, CHEO is suggesting 30 mg per kg per day, divided TID or BID. So just to show you a little bit more of the app's interface, there's a whole host of infections that are listed in this app. And even for just routine primary care, there's also a quick reference to the routine immunization schedule. I've also included the Orange Book here again, just to compare the doses there and to highlight the clinical decision aid again. Okay, so now that we went through that, does anybody want to take any guesses for what you would prescribe Jamie instead of penicillin? Okay, so if you said A or E, you're right. If I had said he had an anaphylactic reaction to penicillin, then you probably want to steer clear from the cephalosporins too. Okay, our next case is a 55-year-old gentleman with bipolar disorder, and he's on lithium, 600 milligrams per day, but his psychiatrist retired, so now he's presenting to you to renew his prescriptions. He's also on ramipril, or an ACE inhibitor, for his hypertension. And so you have to ask yourself, well, what should I take into consideration before just simply renewing his prescription? So for this type of question, I almost always consult LexiComp. It's got thousands of drugs listed, and it's got other useful tools. So it's got this drug library. It tells you about interactions. You can enter the names of the medications and quickly find out whether there's an interaction or not. There's also drug calculators. One of the downsides is that it can be quite expensive. There's a free 30-day trial, but then you have a monthly subscription fee of about $30 per month. At Primrose, I know we're fortunate enough to have LexiComp built into our EMR. And recently one of our residents informed me that you can actually download it to your phone as well, free of charge. If you are at Primrose or at Février, I hope it's the same in other locations as well, or you may want to consult with your hospital or institution because they may have like a hospital subscription. And I will say this is probably the app that I use the most. So again, I talked about the drug library. Other useful things about LexiComp is even for, like, say I wanted to learn more about bipolar disorder, they have like this 5-minute clinical consult where you can learn more about a disease or condition. They've also got lots of patient education materials, not just for prescription medications, but also for natural products, which sometimes comes up. So again, in our case, we really want to know what are the monitoring parameters. Like you think, okay, I probably want to get renal function and how often, certain electrolytes. Of course, you want to check a lithium level, and it sort of goes over how often. And then what are the reference ranges? So where should the lithium level be? I also like that they have sections about how would you change the dosing if this was an older adult, or if they had impaired kidney function, or if the patient was pregnant. So again, you don't necessarily need to get a specific app for pregnancy and lactation. If you have LexiComp, it also is powered by the same corporation, the Wolters Kluwer's organization. In terms of drug interactions, I mentioned that our patient's on an ACE inhibitor. And so on the app here, it lists all the different interactions possible, or a quicker way, if you don't want to keep scrolling and scrolling, you could click on interactions here, and then you can type in the 2 drugs or however many drugs that you want to analyze. So I'll click analyze. And then it says here, there actually is an interaction. So you click on it to learn more. The risk rating is D, which says consider therapy modification. And the reason for that is that the ACE inhibitors can increase the serum concentration of lithium, thereby contributing to lithium toxicity. And it gives you a few suggestions on how to mitigate that. Another app that was also a book before is the CPS mobile app. So CPS, the Compendium of Pharmaceuticals and Specialties. Raise your hand if you recognize this blue book, or you've seen the very thick books. So they are sort of obsolete now. So the good thing about the app is that it's updated weekly. It's available in English and French. It's available on Apple and Android, and it's free if you're a CMA member. So if you pay your $200 per year CMA membership, then the app is at your disposal. I think you just need to make a username and password, and then you can use it. So just to illustrate a different app, for lithium, again, it says what strengths does it come in? You can click on adverse reactions to see all the different side effects. You could click on, it's nice to have the app because then you can just jump to whatever section that you'd like. In particular, if we're worried about monitoring, I like that it's in this nice little table, where as opposed to the LexiComp, it was all sort of listed like this. And so it tells you, how often are you checking things and what are the different things to check. It also has special sections for renal failure and how to make changes if someone has a low eGFR. It also has a section on pregnant women and also nursing women. And also for drug interactions. The same information is there for lithium and ACE inhibitors, but it doesn't have as good as an analyzer like I showed you with the LexiComp app. Another app is called MMEd. This one is also free and at your disposal if you are a CMA member. It does have a drug library, and you could look up the specific drug that you're concerned about. So in our case, again, lithium. However, it also has, similar to Up to Date, it does have lots of topics if you wanted to search. So again, if you wanted to look up bipolar disorder and learn a bit more about that, it also has information like that, whereas LexiComp doesn't. Okay, so I think we have time for one more case. Kate is a 66-year-old lady with diabetes. She's presenting today for a routine diabetes check. Her A1C is very good with just metformin alone, but her blood pressure has been high the past few times you've seen her. And you both agree it's time to start an antihypertensive, but which one will you choose? So again, any of the apps I talked about earlier, like MMEd, if you wanted to look at diabetes and hypertension, you could use that. But specifically, if you're looking for what medication to start, what dose to start it on, a good app is the RX Files Plus. Once again, this was also a book. I have a copy on my bookshelf, but it's has a lot of pages to flip through in very, very tiny font. So it might be useful to get the app. And the app is free, but there's a yearly subscription of about $100 per year. So I have a few screenshots of the interface for you guys here. If I click on cardiology, it'll list the following for me, and I'll click on antihypertensives, and then it gives me an option, ACE inhibitors, beta blockers, calcium channel blockers, diuretics. There's even an antihypertensive summary for guidelines and trials. So if you click on it, it will say, maybe for someone who's diabetic, maybe best to start them on an ACE inhibitor. And in the screenshot here, you'll see a copy of what the table looks like, but on the actual app, you can zoom in to be able to read better. So it lists the different types of ACE inhibitors there. What doses does it come in? What's the cost? What are the special considerations? So I've enlarged it for you guys here. So yeah, there you go. And it also lists the cost for you as well. Okay, and another app, if your patient, is worried about cost, or you're wondering, is there an LU code for this, or is it covered under ODB? It's called Prescribe Smart. This one's also free, but unfortunately just available for iPhone. So if you're an Android user, I'm afraid you'll have to use like the old-fashioned, like looking on the ODB formulary and looking to see what LU codes are available. So if I want to look at my ACE inhibitors, and I'm thinking of starting Kate on Ramipril, I'll say, oh, good, it's covered. Or even if it's not covered, at least it'll tell you the cost, because our patient's pretty young. She might not be on ODB, but it tells you what is the cost per each capsule. Okay, so there's a quick summary for you there about the apps that we've talked about today. And I think I'm good for time, and we've got time for some questions before you guys have to leave to your clinics and to help with the SUS. Okay, so Peter's asking, do you feel that use of an app fosters or hinders patient-centeredness when used for clinical decision-making during the consultation? So personally, if I have to go look something up, I will often excuse myself. I'll say, I'll go print you the prescription and be right back. And then so I will use a different room to do that. But I don't think it should take away. I feel probably Dr. Ng has stronger opinions about that since he's the expert on the patient consultations. But I know he's getting ready to go to SUS. So to answer your question, I think if you were pulling out your phone in front of the patient, perhaps, but often I try to excuse myself and step out, and we'll do my research there. Dr. Yolanda, I see your hand up.
Hi, Rita. First of all, that was great. Super helpful. I've already downloaded 3 of the apps that you've talked about. But I was going to say, I find, especially when we're teaching the residents, the residents, I mean, their phone seems to be glued to their hands at all times. But I do think actually though that it's very useful when you're teaching and you're mentoring residents to have a few apps, you know, that we say like, oh, these are like really reliable, these are great. Because sometimes sometimes the apps they're using may not actually be the best, or they may be like American. So, you know, the data they're finding, I find that they pretty well just kind of always go to up to date, which again, you know, has its pros and cons. So I think this is wonderful, like to have like a nice list of some really reliable, like user-friendly, but, you know, apps that we can actually like you use very, you know, very well. I love RX Files. I still have the book for my old eyes, but I have to say the app is very, very good actually. And then of course it's updated as well, because with the books, of course, they are out of date more quickly. So the apps are nice that way. So thank you. Fantastic.
Thanks, Yolanda. Sharon?
Great presentation and some really useful resources. What have you looked at all coming down the pipeline of the apps incorporating more AI algorithms, and how as physicians or healthcare providers, we can use these as tools? I'm just thinking that the future might be next week. We will be having apps that are looking at the available, whatever has been done, and then giving you recommendations. Whereas right now we sort of think of them as pretty static based on a review of the evidence that was up to date as of January 2023. I think we'll be moving to real-time updates. And I don't know whether you'd come across any apps that are already doing this, or guidance for physicians using them.
I'm not familiar with any that are already doing it, but I think it definitely is coming. For example, like if a patient has a rash, you could probably use your phone to like look at the rash, and then maybe the app will like say, oh, most likely diagnosis is probably this, differential diagnosis is probably this. So I think it's definitely in the works and coming, but it's kind of scary to think about, because like, will I be out of a job? But
well, that's a whole separate question, one that needs studying. But I think there's also the issue of we will need guidance with these once they're used. You know, you can go and you can do your homework on the apps that you've suggested. You can look at what was the review, who's been involved in it, how are they presenting the data that we rely on. But it's based on a fairly static protocol, etc. Once we're moving more to the AI, sort of, you know, the chat GPT fuel type ones, we won't know what they're basing their information on, I think, with the same extent. And just, we may need some guidance as to are the data that they are basing them on similar enough that we can be applying it to our patients, or where are the outliers? And I just hadn't seen anybody doing that work yet. But I think it's moving so quickly that needs to be done.
I think they are working on it. Yeah.